Thank you, Mark, and thank you for putting this together. It's really a who's who of addiction in the U.S. And the impact on the world. Ryan, I want to thank you for your commitment in this area, so important. Monica, it's been great to meet you prior to this meeting, and also to see the energy you're doing here, Bob. The whole team has really been great. This side of the room all knows what I'm going to be talking about, so I'm really focused for you all. And I'm also thinking, you have some big decisions to be making as far as, what to be moving forward with, how to organize it. I do think some of the brainstorming that we've had in the more smaller meetings are really going to be the kind of thing that's going to lead to putting together this model program that could be implemented and tested. Here's where I am most of the time. That's our Lake Quinnipiac, which looks like a river, but it's a lake. My office is in the way up in the top right corner, the 7th floor. They put Psychiatry, and I get that great view every day. I'm grateful for my role and the 342 faculty and 2,000 staff that I get to work with, a great team. So some of the decisions we're thinking about, I think about every day. We're starting new programs every day, small programs, whether it's autism, addiction, co-occurring disorders. And also I'm changing cultures routinely for a large group. How do we get more clinical research going on? How do we bring in wellness? Here I am at UMass Medical School, where the mindfulness center is with John Kabat-Zinn, and psychiatry had nothing to do with mindfulness. Now we do. We have integrated into all our clinical services. So, Ryan, one of your questions I thought is very important. How is the workforce going to adapt to the wisdom that this group can put together? Even at the recovery house that we went to last night, it had many strengths, but you could feel some of the gaps that I think could be strengthened with a kind of panel and team that you have here. One of the areas that it could be strengthened, I'll be talking about with co-occurring disorders. I'm hoping that we can think of a program that might be in Massachusetts. Boston obviously is an attractive city, but you don't want to have your program right there. You'll want to have it somewhere between Worcester and Boston or in that area. We don't have anything really in the Northeast that's of the nature of what we're talking about. McLean has a nice dual diagnosis program, Silver Hills also, but really there's not much else there, so there's a wide gap and a big geography. All the other symbols there are related to different kind of programs that I've got going on in research, or the VA, tobacco area that I'm working on. For you all, co-occurring disorder, you've already heard the themes that co-occurring disorders is big. Bertha didn't get to talk about the bullet on her slide. 42% of the patients that she described had co-occurring disorders, and if you look in a federal program, public sector, it's even higher at 63%. And I would even argue that if you include personality disorders, you probably have a way higher number than that. So I thought others in the room have already talked about how important this problem is, how big it is, and how one of the big gaps in addiction recovery programs, whether it be Talbot's place or some other place, has been the gap of adequately addressing co-occurring disorders. You have to do it. It has to be part of what you do. Herb Kleber, one of my mentors when I was at Yale in the 90s, I remember I listened carefully, try to be a sponge to all this stuff. I'm learning a lot from you guys just coming out here. I don't usually hang out like Mark Gold with venture capitalists and come up with these big, brilliant ideas. But Mark's been a mentor, and I also learned from him, even though we're colleagues as chairs. But I do think it's going to be very important of how we think about including addressing co-occurring disorders as part of the story. There are many subtypes, so whether it's Dan's work with thinking about personality disorder subtypes and how to do a good screening and assessment when patients come in, and then how does that impact with rippling for treatment, I think is going to be very important, which tools we pick. Training the workforce to integrate that and accept that as part of what we do, I think will be very important. So high rates, it's obvious. Many subtypes, so people often use it like dual diagnosis, like it's actually a word, co-occurring disorders. It was really to highlight what was the problem in the 80s, that we totally different treatment systems. We have an addiction system, a mental health system, completely disconnected, and how do we provide treatment that's more of an integrated nature. There are a lot of symptoms that occur with co-occurring disorders that are both common to somebody who just has an addiction, but also will be worsened by it. The most common problems are going to be mood disorders and personality quirks and anxiety problems, including trauma history. Most people have a trauma history. We haven't really talked about trauma and PTSD here, but that's obviously a very important component. As a chair of a large department, $142 million budget, again, not as big as you guys, but big enough for psychiatry. I'm thinking every day on the level of the clinical interaction with the patient and the team, as well as the program, and how do you make the program solid and evidence-based and outcome-oriented, and also on a systems level. How are we going to do this at multiple places? I would see the system levelness will be if you have multiple sites and having some consistency in theme and the brand that you're going to create over time. A lot of my research currently is on, I went from doing imaging work with Lou Baxter and getting all excited about, wow, in the 80s, cocaine addicts' brains are different than others. I was equally excited with Lou Baxter's research when we showed that psychotherapy changes the brain. So here I am as a young resident saying, wow, addictions change the brain, and I can actually do therapy to change the brain. Meds made sense that it would change the brain too, but showing that recovery could also change the brain. I got a study right now with the NIH to look at mindfulness-based stress reduction and how that changes the brain. Substance use disorders, many of them, DSM-5, everything's changing. Don't want to forget about tobacco. It's the leading cause of death of our folks. Most patients smoke, 66%. If you're in a methadone program, 95%. It shortens your lifespan 12 years. Hertz data, if you leave an addiction program, in recovery, work in your program, doing everything right, but you keep smoking, you're going to die. 12 years shorter lifespan. Death. So I hope that's a part of our outcomes also. Process addictions. David, great mentor of mine through the years. You know, I was lucky to be embraced by the California Addiction Society as a resident here, and Garrett O'Connor is one of my great mentors too. Talking about the process addictions, it's an important component, would have to be part of what we do as we're looking at individuals, gambling, internet, sex, food. I'm doing a lot of work in food right now with our bariatric surgery group. We have 500 surgeries a year. You know, those are the alcoholics of food. And what are we going to learn from that group? I'm very interested, so I'm meeting in groups with them, even with my busy schedule, just to understand them. And it's interesting, OA and FAA and all the 12-step recovery is nowhere near any of that treatment. Just bringing that in, I think, would add another dimension that isn't being looked at. Can the addiction lens increase a perspective on obesity in our country? And I believe it will. And medical illnesses, we're seeing that all the time. So I'm not really going to cover all the slides that I've got in the packet because I don't think I want to torture you with all the data. This group knows it. I'm just going to kind of do flashes. So we know that there are a lot more problems with co-occurring disorder, particularly suicide. So bad outcome, 5 times the risk for suicide if you're a substance user and have an addiction, a mental health problem. We've gone over the brain. This is my brain split in half if you're looking at me this way. These are the core 4 regions that you've heard the great presentation on the neuroscience and functional connectivity, reward, memory, learning, motivation, inhibitory control. All of those things play out, make this a complicated area of interaction of brain, pathology, and substance interaction with medications. We see different parts of the brain that we can really identify. Again, exciting area. The brain changes with chronic use, actually looks different. It changes how we assess patients and how we treat them. I've developed a dual recovery therapy, learning about healthy living manual, a bunch of treatment manuals, been a lot of my research area. How do we get those evidence-based practices? If you're going to bring meds into the equation, how do you do that? The AA members and other drugs, how does that come into what we give out to individuals? I'm going to conclude with a sentence that Herb Kleber taught me, which I took a break from. He said, Doug, you know, the interesting thing about this field is we circle the wagons and shoot inward. So we've got the 12-step group, the medication group, the psychodynamic group, the pharmacology group, the family group, the medical monitoring group. And even in this room of like-minded spirits, you can feel the subtle tensions. And again, you have to be kind of smart enough, for me, I'm listening to the magnifying glasses, that even in our group, we have the subtle tensions of which is more important or valued. And I do think the model program will really be an educated group that considers the wide range of them and puts that together in it, and values and respects the different approaches.
Circling the wagons is a very human thing.
Yeah. Well, we in addiction have perfected it. Thank you.
It's you, Barbara.